We are broadcasting in live.
Okay, welcome. Yeah, we're back to our third presentation today. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. All these webinars have been brought to you at no charge because of the kindness of our speakers that have volunteered their time and their expertise. We appreciate that. We have over 50 webinars in the can that are on our YouTube channel. To get to our YouTube channel, that's Washington Academy of General Dentistry. Please check us out there. If you struggle to find that, go to our website. Go to www.washingtonagd.org and just look for the YouTube symbol, click on that, and you should be able to navigate to our YouTube channel. Remember to like, subscribe, and click the bell there so you're notified in upcoming webinars as they're added to that YouTube channel. We're a little behind on some of those webinars, getting them up. We are doing our best. For instance, Dr. Troelsch's webinar from this morning should be up in the next couple of hours or so. We had a little change in our schedule. Tomorrow, the Brays won't be on doing their webinar. Just quite simply, there was nothing new to add from the federal government on PPP loans, etc. We'll look and see if we can do something in the evening next week. You're going to see some flyers going by with upcoming webinars that will end this webinar series for us. It's been a lot of fun. It's been a good go and a long hours in the chair. And so, speaking of long hours, I'd like to thank our Executive Director, Valerie Bartoli. I'd like to thank our panelist, Dr. Gary Hayamoto, for helping with the webinars, and our CE, one of our CE chairs, Dr. Herbert Edwards. Thank you very much. We'd especially like to thank the University of Washington School of Dentistry CE department that's supporting us by sending out the CE credits. You'll be receiving your CE credits from the University of Washington in a few days. They'll come in PDF format. Remember, put your name on that PDF and save it for your records. If you're an AGD member, we will send your CE credits directly to the Academy of General Dentistry. Those will show up on your transcript within 2 to 4 weeks. There's just a real backlog with CE credits. Just a reminder that Dr. Yassine will be doing his final implant study club part 5 tomorrow afternoon. Please join us for that webinar. And also space available on Friday. We'll be putting that up on our website. You can register. Dr. Yassine has a day-long course that is not part of the Stay Home, Stay Healthy CE, free CE. That's a different paid for event. So if you're interested in doing that, we're going to try and keep the cost down for you on that. We are close to our start time and people are really funneling in here. So that's great. We're getting our numbers up. Just a reminder, we've had good support from our corporate sponsors, Comet USA, Patterson Dental. We'd like to thank the Canadian Academy of Restorative Dentistry and Prosthodontics for your kind donation today to support these webinars and what we've done over these past weeks. We appreciate it. We'll look forward to future CE events with our friends from the Great White North there. We'd like to thank the Arkansas Academy of General Dentistry for promoting our webinars. Thank you, Dr. Kenton Ross. We'd like to thank the International Academy of Nathology for helping out with speakers last week. Thank you to Paul Hasegawa for that. And again, thank you to CardP for supplying speakers last week as well. Thank you to Dr. Peter Thompson from Nova Scotia. Appreciate that, guys. These QR codes will take you to either the Washington Academy of General Dentistry.org site. You'll see there's some flyers that of webinars that have already occurred this week. They were really, really well done. Dr. Chad Dorf and Dr. Mark Donaldson did a great job yesterday with the suicide intervention and the opioid class. That was a wonderful member benefit for our AGD members that were able to attend that series of webinars that satisfied our state requirements, and there was no fee for that. So thank you to our speakers yesterday. Reminder, our 2020 and 2021 Master Track program is still has a few seats available. That will be starting up in the fall. It's 4 sessions. Each session is over 28 hours of CE credit, and it's designed to be hands-on CE credit to help you get your master's. If you jump on board with that program and did all your case presentations, you could obtain your master's in a period of about 5 years. That's a way that Dr. Gary Hayamoto structured it. Wonderful group. I did that with the inaugural group, and it was just a fantastic experience. So we're getting close to start time. Yes. Oh, we still have a minute. I guess I'm talking fast today. Tyler Jones is with us Thursday at 1 o'clock, going to talk about human resources issues and office manuals. Just a reminder, in coming up, we will have a botulism toxin course for dentists here in Washington State. We also have a course for young dentists called Crown Preparations 101 from analog to digital that has been really well received, and we will be doing that, I believe, in August. I'm sorry we had to reschedule that. Thank you to our sponsors for helping out with that. That's Bean Air, Kettenbach, and Comet USA. So we are at 2:30. And that means it's time to start our last webinar of the day in our Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. For those of you that are new to Zoom, play around with your interface. You can resize the windows. You can open the chat feature to see comments that are being put in there by Dr. Gary Hayamoto. You can make comments there as well. If you have a question, questions go in the Q&A section. They do not go in that chat feature there, please. Let's keep them in the Q&A. It allows me to moderate those. Also, we're not using the hands up feature today, so don't bother with that unless Dr. Karbakhsch asks us to raise our hands, and we can do that. Otherwise, we will not be using that feature. Today, we're going to be getting ready for practice, evolving systems, answers to your questions. These are the questions we didn't get to last Friday. Dr. Karbakhsch has worked extremely hard to put together, kind of categorize your questions and lump them together. But if we don't quite answer your question completely, type something in the Q&A and we'll see if we can get to that. Dr. Karbakhsch, are you ready?
I am as ready as I can be. Absolutely.
All righty.
Thank you very much.
Thank you very much again for doing this. You put a lot of effort in after last Friday.
My pleasure.
We appreciate that, and welcome back to everybody that was here last Friday. I'm going to let you start sharing your screen. And I'm betting you're becoming a Zoom expert, huh? Okay.
Are we good?
We are, yes. Beautiful. As I say, you're becoming a Zoom expert.
You are complimenting me, and I will take any computer can compliment any time of the day. My IT guy is, he's wonderful. He will be very happy when I graduate with a Zoom diploma. He's been working around the clock to facilitate that for us. So, Dr. S, you're giving me the floor. Thank you very much. So I will take it from here. Welcome back, and I will very briefly introduce myself. for those that may not have been in the Zoom meeting for last Friday. My name is Dr. Minou Karbakhsch. I am a periodontist. And my background is in Germany. I went and received my dental training in Germany. I specialized at the University of Washington in periodontics and had the discourse in implant as well in the prosthetic department. I've been in private practice since '99 and have had a great opportunity and pleasure to work with outstanding clinicians and wonderful patients and absolutely fantastic hygienists throughout my career. Today, what we are going to be continuing, and Dr. Hess has said that earlier, we had a, I said that last time and I will repeat that. I thought this is very, very unusual times. This is a time where from one day to the other, our lives change. Our routine as we know, our daily routine as we know it changes from one day to the other. We're busy, dentist, periodontist, specialist, we're going to practice, we're taking care of our patients. And then out of the blue, there is this new virus that comes around that no one has heard about, and we cannot gauge it, but it is powerful, and it turns out to get us in a complete lockdown and shutdown. So from one day to the other day, we're losing our routine, we're losing everything that is dear to us, we're losing our life. And last time we have had the opportunity to, since we are talking about evolving systems, how are we surviving this time as we are in practice? How are we emotionally coping with all of the losses that we have to provide an emotional niche? Because it becomes overwhelming. We don't know what we do. We don't know what is going on. We feel lost. And we certainly feel that we are the only one that is lost. We took a discourse into the grief process, a curve of change that comes with the process of grieving. And I introduced that, my apologies, last time. We talked about what is it? What is it that takes over our life? What is this virus? What has it done to us, to our profession, and why does it affect us? Well, it affects us because it is a pathogen, it is a virus that is in the oral cavity. It affects us because it affects our livelihood. It affects us because there is a very high risk of transmission, of infection, and uncertainty for all involved: patients, hygienists, doctors, clinical assistants. And it involves us and affects us emotionally. So we took a long time to talk about all of these last time. And we visited the science that is behind and what we know till today, what is behind SARS-CoV-2, also known as coronavirus, what we know about the science, and what the risks are. We took a much larger discourse into the emotional landscape of the professionals, hygienists, our dental team, and us doctors. And especially us doctors, we are so used to go, 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 to be so action-oriented and so focused on solutions that we do not give ourselves permission to stop, to think, to reflect. We don't give ourselves the opportunity to decide where do we want to go and what do we want to achieve. The curve of change that was introduced, I will very briefly review it for those that may not have had an opportunity to see that. Dr. Elizabeth Kübler-Ross, who is a Swiss-American psychologist who had passed away in 2014, wrote a book about that and depicted phases of grief and the process that is involved with it. And on this slide, you will appreciate the moment that the shock or the event hits, the surprise. And on the right-hand side, you will recognize the actions that go with the curve of change and the grief. In the first phase, we usually want to know after the shock, where do we stand? What is going on? The second phase, the denial, frustration, we start to talk, we start to communicate, and sometimes we feel that we are not heard, and sometimes we need just to have the space to process. It affects us, it affects our team. And the third phase of it, we will start to spark motivation again. We are at the lowest phase. We're lacking energy. We're hopeless. We don't know how this is going to end up, where we are going to go. We think we need to perform, we need to do something, but we can't. And the tricky part about this curve is, about this process of grief, of letting go and processing, is that it is not linear. It is something that one can jump from one position of depression to denial, to integration, and it is fluid. In the third phase, we share with our team members. We start working. We want performance, but we truly have to show appreciation, and we truly have to show value for all of us, for all of our team members, and for all of our community. And we just want to know and feel that we're okay and that we matter. And as we come out of the valley, and this is the area that we are today, we'll develop the capabilities. Now we feel that we see the light at the end of the horizon. We want to grow. We want to acquire new skills. We want to implement the new tomorrow and create our new practice, our new future, our new life. So this is the time when we need coaching. We need to be our own change agent, and we need to be each other's. We have to keep focused, keep coaching, maximize the performance, the feedback, both critical feedback, but also positive. We will move quickly through this into the fourth phase and the fifth phase, which is the developing of the capabilities, and then the most exciting phase, and this is the phase that we are approaching, is the phase where we share the knowledge, where we come together, where teams work together. So these are the things that we had covered last time, and I took a short time to show you those phases, from creative alignment, as far as the actions, to sharing knowledge. Today, we're going to do the following. We're going to do the third part, and Dr. Hess invited me back so that we get an opportunity to answer all of the practical questions, because right now you are in this phase where change is occurring, we are motivated, you have acquired the capabilities, you have done research, the teams have come together and they want to have answers to certain things. So it is a very important part to put the facts, the science, the emotion, and what can we do in order to have our start. And I will share Is the audio good?
It's not great. When you shared your screen, did you select the computer audio aspect?
I didn't.
Okay. If you want to restart, why don't we just stop sharing your screen and we'll share it again. And then when we bring up the share window in the lower left-hand side, there's two little things you'll select, and that will select your computer audio, and one will smooth the video also.
So which one was that? On the...
Well, when it brings up the window for sharing, and you can see multiple desktops, in the
Yes.
lower left-hand side, there should be two things that you can click on. One for sharing your computer audio, and the other one is for smoothing the video on optimizing the video.
Hmm. Is it in the microphone area? No.
No, no, no. So when you press your share screen,
Yes.
that pops up. You should see something in the lower left-hand side.
Let's see.
that
Chat,
will say
Q&A,
share.
participants, stop video, mute.
Okay. No. So have you pressed the share screen? The green button?
Yes.
Okay. And now you should.
Share computer sound. Got it.
Yes. And
Got it.
also click the optimize screen sharing for video clip. Here I was bragging you were a Zoom expert.
You jinxed it. I am so...
That is
Oh.
my fault. Okay, thank you.
For vampires.
Okay, let's go back.
Hi, I'm Dr. Chapman. Thanks for coming in today. Well, thank God dentists are back to
Better?
normal. Yeah, we had to add a lot of safety protocols for the coronavirus. But before we begin, let's start with 5 Hail Marys. I'm not religious. That's okay. It's just encouraged by OSHA. Now I'm going to need you to throw some salt over your shoulder. Okay. Are you superstitious? Not at all. It's part of the new CDC guidelines. Here, go ahead and put this garlic around your neck. For vampires? No, it's part of the ADA recommendations. All right, fine. I'm just happy to get my filling done today. We're just glad to be back full time. Wait, were you wearing that when you walked in? Oh, it's just our new coronavirus precautions. Is this even necessary? No one really knows. Stay open just like that.
So this is the audio back?
Yep, you're good.
Okay, I couldn't hear. I cannot see you. That's why I cannot. I was.
Okay, no problem. Yep, you're good.
I was
You're sounding great.
absolutely. So I cannot see you. So I cannot. I don't know where if the audio is on or not. So let's summarize what we know as of today. What we really want to know, and this video clip, which I thought was really, really clever and amusing, summarizes more or less what we are, in what situation we are right now. So the knowledge, the science, and the compliance with guidelines of our organizations need to be respected. So let's take a look at what we have looked at. SARS-CoV-2, also known as coronavirus, is an RNA virus. We have known it since the 30s. There are 6 different coronaviruses. 4 of them cause very mild symptoms. There are 2 of them, SARS-CoV-1, which had an epidemic in 2002, and MERS-CoV, the Middle Eastern virus in 2012, were severe. They have caused 10% and 37% mortality. And now we have a new member of the family, Corona or SARS-CoV-2, that has merged the family. What and how does this virus affect us? This virus enters our body through mouth, nose, eyes. It attaches to the mucous membranes, and it is mostly transmitted through large respiratory droplets. The virus itself is very small, but when it enters the body, it affects the lungs, heart, pharynx, and GI tract. It basically goes everywhere. Now, I realized that there is, and a few of my colleagues brought that to my attention last time. There is a confusion between medical and dental understanding of what a droplet, what aerosol is, what a droplet nuclei is. So I want to clarify some of these words that we're using here. Respiratory droplets are larger particles. They are those particles that when we speak, you almost see in air, the little spit particles, almost. Okay. They don't travel far. And I always, the way I remember that when I was in school, in a medical school, is droplet. So if you look at the first 4 letters, it drops, which means it doesn't travel far, it's heavy. And it is not aerosol, it's not light, it is not a small particle that lingers in the air like aerosol. Okay? So what we know is that this virus transmitted through respiratory droplets of the largest sizes, and the infection occurs through entering mouth, nose, and ear and attaching to the mucous membrane. Now, how does it affect us in dental office? When we think about this, patient comes in, talks, sits down, sneezes, coughs. Where does this virus land? It lands everywhere. We basically know that through this transmission, the virus goes everywhere. What we don't know today is if this virus is also present in the light, smaller aerosol, which is droplet nuclei. Okay? The little particles that you cannot see. Now, if it lands everywhere, how can this virus be transmitted? Right? It can be transmitted by direct contact. You touch a surface and you touch your face, you touch your nose, you touch your eyes, you touch your mouth. And of course, through water, dental unit water, and aerosols. Summary, slide for practice. What is important? People transmit it. Virus can be found in air and all surfaces, enters through the mouth, nose, eyes, and can have asymptomatic carriers. What we know also is that fresh air filtration is beneficial. What we also have learned from our last presentation on Friday is that high vacuum evacuation is very efficient, that our PPE is very effective, that the disinfection methods that we have kill the virus, and that the sterilization is effective as we have it in our practice. So let's look at the chain of infection that we have, because what really is important in order to get back into practice to understand what factors do we have to control, what factors are important, where do we need to put the training in, and what guidelines do we have. Now, the guidelines that we have is set, of course, by our regulatory agencies. The WISHA, state equivalent of OSHA, keeps employees and the workplace safe. And of course, we do have to be in compliance with them. Now, as clinicians, we look to the ADA and the CDC, Center of Disease Control, which provide us guidelines for practice and infection control. And DQAC, of course, then again is a regulatory commission that makes the law based on the CDC and other agencies' recommendation. Now, our action steps in practice have to be in line with those and with the science. There are no changes that have been adopted so far by the OSHA, Occupational Safety, Health. I think I'd never get this right. But they did outline 3 recommendations. They outlined practice hygiene, maintain social distancing, and eliminate unnecessary public interaction. These measures that are implemented are basically measures for us as clinicians and also as people to form new habits, personally and also in our profession. And what does it gear towards? Is to learn how to coexist and deal with a new virus, with a new threat that has entered our personal life as well as our professional life. So we have regulations and we have guidelines. There are controls for the exposure to this virus that have been put into place. Administrative controls, which are more in scheduling, screening, and we'll visit that very briefly, engineering controls, and work practice controls. We do follow infection control basics by utilizing regular standard precaution. Nothing has changed really in how we approach based on our regulatory compliances and how we practice. So we must adhere to standard precaution, which is a transmission-based precaution. It is based on the blood-borne pathogen and on the statement that all body fluids but sweat are infectious. We need to do the procedures as dentists as we were trained to do. How does it now affect us when we are looking at coronavirus, at the SARS-CoV-1, and look at the presence of that in the operatory? It's for sure will affect a lot of the factors that are involved in the chain of infection. And how and what steps do we have to take? Training steps. And for that, there are 6 instances that I call for the office COVID training. And they're designed to keep the team and the patient safe, based on CDC guidelines, which also are medical, not only dental, for infection control, ADA guidelines, which are dental, and then OSHA and WISHA. Now, PPE, health, and the office, the surrounding that we work in. How do we put on PPE? When do we put it on? Health, what do we need to do? Do we need to wash our hands? How often do we need to do it? Do we need to take care of ourselves, get a flu shot? All of those things are recommended to be the best and the healthiest that we can be, okay? We need to monitor our health in the office. We have to check our equipment, our units, right? So that there is no transmission of the disease that can occur by us neglecting it. Our sterilizers, our nitrous system, amalgam separators. And I know that there were some wonderful presentations to that. I am by no means I by no means work for OSHA or WISHA, and I'm not a virologist either. We need to prepare our offices to declutter it, to remove clutter, for the lack of a better word, that can catch and capture the virus. We need to place trash cans. We need to organize our supplies in a way that will minimize cross-contamination in the office. The operatory is the same way. We have to cover keyboards, we have to cover mouth, we have to change between patients. We have to manage the patient flow, the traffic flow into the operatories. We have to wear personal protective equipment during disinfections. And we need to screen our patients. We need to screen our patients, and we need to screen the staff equally. And the screening process is one of the most important processes in management and mitigating the risk of exposure in this. And all of that said, we also have to educate the patient. The patients, the changes that have occurred to them emotionally and life-wise is the same. They cannot assess and see what we know, what changes we have gone through, what changes we have made, and what measures we have implemented in order to provide them a safe and a sound environment, all in guideline with the recommendations and guidelines of the ADA, CDC, and of course legally. So how can we do that? The first thing is that it starts with the source, with the human. And what I will be doing in the next phase is a lot of the questions that have been answered, now that I've grounded them in the surrounding of what our guidelines are, what our legal requirements are, what we're bound by, and how we can include the science into these processes, how can we mitigate the risk, and how can we practice and continue to practice dentistry with updated systems that will allow us to coexist with a new virus that is quite aggressive. The first thing that we do when patients come in, and this was a question that has been asked by many, and many of you have reached out, is the pre-procedural rinse, which is an office preparation of a 50-50 dilution of 3% hydrogen oxide with Listerine. Now, the nice thing about this is that it not only tastes much, much better, but it also can extend the shelf life, prevents the oxygenation. So I have a little movie here that I will be sharing with you on how to prepare the solution chairside for your patients before the patients even arrive. One of the recommendations is, and we received that from our consulting pharmacist, not to buy the hydrogen peroxide at a compound pharmacy. Buy it at Walmart or any other place and have the bottles ready. They have to be dark, light cannot come in, otherwise it oxidizes it. Pour equal parts with a little cup and then join them together. And your pre-procedure rinse is completed and ready for the patient to use. Now, you of course also have the opportunity to make a little bit larger and pour that in a bottle for safekeeping.
Light protected bottle.
Again, it is important to have equal parts on these. Any questions at this point?
Yes, we have a couple of questions. Any additional information guidelines for pregnant hygienists returning to work?
Excuse me, you a little. Can you repeat?
Any additional guidelines for pregnant employees such as hygienists returning to work?
Well, I'm not an attorney, I have to say that. And I am not sure how to answer it, because it depends certainly on the stage of the pregnancy. So I think this is more of a how do I say it? Maybe more of a legal question. I mean, as long as somebody is healthy and the gynecologist and any other health problem don't prevent somebody to come back to work, then I don't personally see a problem. But then again, to the best of my knowledge, this is all I know on labor law.
Yeah, I think that's just good advice that the person that is pregnant checks with their physician and follows their guidelines in this. And I think they'll probably have better advice than we will.
It always depends. There's high risk, low risk. It's I'm by no means an expert there. So yes, definitely.
Okay. Somebody asked the questions, advise best practice in the following situation: open bay, operatories, pedo patients with parents and possible interpreters, etc. Also, are waiting rooms now obsolete? Yeah, I feel for the pediatric dentists and the orthodontists and the open air concepts. I would guess they're almost going to have to go to every other chair or something and just try and really limit, you know, the support people that come in. So, yeah.
Well, absolutely, Dr. S. This is open bay and people that is a problem. I mean, a lot of technologies, and it really brings to mind a very, very sad story that just happened. You know, we had this first seminar on Friday where we talked about the emotional strain and stress that has been imposed on doctors, on staff, and that unfortunately has led to one of ours to take her own life. And she was a pedodontist in South Dakota, a young, successful pedodontist. The pressures of the time, the pressures of the staff, the demands, and the fear also going back and being in a full hazmat suit were, you know, shared as reasons on why this tragedy happened. And encountering children in a scary hazmat suit, I can imagine how pedodontists feel at this point. And thought on that I had is possibly have you know, virtual communication, you know, with iPhones, with other ways to communicate to decrease really the traffic flow, because it's very difficult, and maybe scheduling in different time zones people, but they have a big challenge. Our hearts go out to the family, and our prayers too of the pedodontist. That's a challenge. Open bay concept, if it's a question of the past, I don't know. We'll see. It really depends on the guidelines and the regulations that you know, the law is going to come up based on the science that we see emerge.
Okay, specifically on mouth rinses, why Listerine? And there was also a person that said, Dr. Troelsch on an early webinar suggested just 1% of hydrogen peroxide for 1 minute rinse. And so, and there was another question, how long should the rinse be for?
You know, these are great questions, because we have a lot of different things. We have 0.5%, we have 1%, we have 1.5%. But the fact is that this virus doesn't like the oxygen. So we have recommendations from rinsing 3 times with 0.5% to rinsing 1 minute with 1.5% or 1%. What Dr. Johnson has recommended here in Seattle was 1.5%. And that reduces the viral load by a log of 4. And I'm not a virologist again, but he is. And it significantly reduces the viral load in my understanding. And that is all we can do. And it's not only rinsing, you must also gargle, because where does the virus sit? It's not only in the mouth, it actually sits the back of the mouth, in the throat. So the gargling part of it is very important too. So what I do is start gargling and then rinse. Gargling and rinse in order to get the maximum removal of the virus. Why Listerine? Listerine is prevents the oxygenation, I believe, to some extent of the hydrogen peroxide, and with that extends the shelf life. And it is a natural enhancer of the flavor.
So you're using the new, tastier Listerine rather than the old yellow, taste like burning Listerine.
I use whatever I have in my practice.
Okay.
That is the honest answer. We have the blue Listerine, the regular traditional Listerine. And I'm sorry, I have a very dry mouth. And this is based on the recommendation of our pharmacist. And I thought that chemically it makes a lot of sense. And it's a regular Listerine. And it does not interact and it does not take away from the efficacy, which is what we want.
Okay, I'm going to read this question so you can just clarify this for people. If there is no proof of airborne transmission, but then the same slide said virus is found in the air and droplets are dropping to the surface quickly because of their large size, then are you saying the virus may be in the air, but not in sufficient quantities to infect someone?
Whoa. Let me try to take it in little pieces. The first question was,
they were making the statement. Basically, they're asking they're trying to clarify between droplets and aerosol and
Yes.
the number of viral particles
Yes.
and infectivity is, I think, the gist of the question.
okay, good. This is a very good question because it's a very, very new area with this virus. Where we have the answer for is that the virus is in the droplet. Droplet means when you sneeze, when you cough, when you speak, and when you're, a little bit wet speaking. That is what a droplet is. And that is where the transmission happens. Known. We have research on that. We have seen it. We have seen it on studies in China. What we don't have really, really conclusive, we hope it doesn't travel in aerosol and it's not alive in aerosol, but we do not have conclusive research there. It is not enough yet to, as far as I know, to really make a statement whether it's there. So far, it looks like it does not travel or is not in aerosol. It was not found in aerosol, a viable, which means an alive, nuclei. Since we don't have a concrete answer to it, what that means in practice, we will be utilizing, based on the guidelines of CDC, ADA, protection. That means we wear masks, eye protection, everywhere where the virus can enter the body, mouth, nose, eyes, has to be protected. So full PPE at this point, when we see the patients, because we know it is transmitted through droplets, we have to have a full PPE to protect ourselves. Second part is it transmitted when we create aerosol? Because we know we have silent carriers. That is something that we don't know. Therefore, we will protect ourselves with the highest level of protection available based on what we know now from the interim guidelines. Does that answer the question?
Yep, absolutely. There's just still some more questions on the hydrogen peroxide, Listerine. You're not storing that. You're just mixing it together chair side, aren't you?
At this point, because we pretty much we went into the COVID break. So we cleared, nothing is, I mean, I just cleared everything out. It's all going to be new. It's all going to be fresh. What I will be doing is, because it will extend the shelf life, I will most likely pre-mix some. It will make the workflow easier, especially when we start practicing again. With all of our PPEs on and donning and doffing, I want to minimize contact to any surface. That also includes touching things in my office. That also includes opening a bottle, closing a bottle, putting it in here, putting it in that, and mixing it up. So a pre-made bottle in the right proportion will provide that. That will be kept in the fridge, then it's one touch and not three touch. And so that will also mitigate the risk of the surface contamination with a virus, let's say, is on the surface, and a possible transmission that could happen. We cut that out. So if I will, when we start again, prepare some bottles.
Perfect. Lots of questions and comments about if the virus is actually in the nose, in the oral pharynx, what good is a rinse?
What harm does it do?
Right, exactly. I think that's the answer.
We know. So let me set something clear. That was a German answer. One of the things that we know is we do what we know and what we learn, and based on a scientific decision, right? We know that rinses will not kill all of the bacteria, all of the viruses that we have in the oral cavity. We are working in a very colorful world in the mouth. We have 400 to 700 different species. Some of them are very, very virulent. Some of them, we don't want to even know really how they, I mean, that just dropped this. What we know, however, is that if a rinse, a pre-procedure rinse, will significantly, based on data, reduce the amount, it will reduce the risk of what we call a possible inoculation, which only means that the virus enters through your mucous membrane, your body, your host. We know from this virus that it is dose dependent. So if you have a big bag like this of virus versus a teeny tiny one, the risk of inoculation, which can cause an infection, is less. It's a very simple logical mathematical formula. Now, if you have a higher load of viruses, the risk of a possible inoculation is therefore higher. So rinsing will decrease the load of the virus. And that is what is recommended, and that is what I recommend. As a matter of fact, EMS is coming out with a new rinse. And I don't know much about it, but that also has been studied and published on as being a effective rinse against or to reduce the viral load of SARS-CoV-2. Does that answer the question? Is there any question on how you get an infection, inoculation, and because that was what we talked about on Friday. Quick summary for those. A virus, when you get in contact with a virus, you have one virus, one surface, that virus hits the surface, it might not be strong enough of a dose to cause an infection. But if you have 200 viruses hit the surface, the mucous membrane surface, the viral load plus the virulence, which is another factor, might be strong enough to now cause an infection. So if we can reduce it, and that is what we do in the chain of infection, if we can reduce the amount of virus floating around in our lives, outside as well as inside of the office, we will create an environment where the contagiousness, the R number, the R naught number of a disease will be decreasing by the mere fact that we are reducing new infections. So rinse, pre-rinse, absolutely recommended.
Okay, there's lots of questions about all kinds of different rinses out there, like Colossus, Oracare, etc. Do you know anything, any thoughts on that?
What works is hydrogen peroxide and CPC. Chlorhexidine does not work. And I am not familiar with other studies that has been conducted on SARS-CoV-2 or the coronavirus. I am happy to look into that. So if you would like, I'm very curious, as a matter of fact, send me the information. I will research that and get back to you.
Thank you. I think that covers it, and that right now hydrogen peroxide is the recommended.
Yes.
Yes, and that it's easy to obtain, it's cheap, and then you can make it taste good with the Listerine. And then again, your protocol was to have them gargle with a little bit, getting it as far back as they can, for as long as they can spit it out, and do that a couple of times until that is gone. Correct?
Perfect.
Okay. All righty. Why don't we get rolling again here, and then we'll keep on top of the questions, and we'll hit
All
you
right.
some more.
So let's go to the most commonly asked questions. I'm sorry, I have a very, very dry throat today. I don't know what, I have a hay fever, so I think that's what's drying me out. My apologies for having my tongue glued to the roof of my mouth. Most commonly asked questions from you were mostly around the PPE, the personal protective equipment, the aerosol, hygiene procedures overall. So one of them, PPE. We need to wear the highest level available when treating patients to reduce the risk of exposure. This is what the the Center for Disease Control's recommendation is for the asymptomatic COVID-19 patient. We all wear what we have, and so you can see on one, and these are two examples. One of my friends has sent me the example, the dressed up example on the right-hand side, in a spacesuit, and everything is completely wrapped up. Now, that tells you of course, hints towards the emotional status and the fear of contracting it. These seminar series or webinar should really create knowledge and transparency so that you feel comfortable in making the decisions. Now, the French dentists on the other side, they don't have PPE. They wear what they have, which in this case is only eye protection. So that way you cannot go and treat a patient. So what is the definition? Anytime there's a reasonable chance that blood, and this is based on the blood-borne pathogen, body fluid or any other material can reach your skin or clothing, you must wear PPE. That lives up to the challenge of the procedure and protects you from exposure and contamination. For COVID, we do not know if aerosol carries a viable pathogen, droplet nuclei, the small mist that you cannot see, the mist that is created with high-speed handpiece, the mist that is created with ultrasonic, or droplet. What happens when you stand in a supermarket line and somebody coughs and sneezes, which in my opinion, I'm much more scared of with PPE because nobody wears protective gear to the level that a dental professional does, okay? So on the right-hand side, you see a full personal protective gear. Head cover, goggles, a side shield, mask, gown over the knee, foot cover. All of that is wonderful. You wear it. But what is very, very important here, and there were a few questions on that, how do you put it on and take it off? And that is extremely important. We do have some videos. I don't want to waste any time on it because I want to get through all of the questions. The donning, which is putting it on, and I learned the trick that there's an O-N in here, means don, put it on, and doff, O-F-F, take it off. Sequence for putting it on. First, the biggest carrier that you always have for any transmission are your hands. Hand washing, you cannot go wrong in washing your hands. However, you must also make sure that you lubricate your hands so that you don't have any breaks in your skin. The moment you have breaks in your skin, of course, you are opening the door to bloodborne pathogens, which in this case, the virus is not bloodborne. But we have many other viruses, like HIV, just as an example. We must always find the balance. Wash your hands, put on the gown, put on the mask or the respirator if you have one, which I don't know many offices that do, goggles or face shield or loop. And at the end, you put on your gloves. Make sure that the glove is long enough that it covers your cuff and not too short. Most of the examination gloves are too short. The doffing, that is actually the most important part. There's two different ways this is accepted and recommended by the CDC. And the first time I read it, I thought, this is wrong. They start with the gloves first. I'm like, wow, you take the gloves off and all of the virus is outside on your gown, on your mask, on your hat. What are you gonna do with that? So CDC recommendation, gloves off, wash your hands, goggles, face shield, the gown, and at the end, the mask or respirator, and you wash your hands. When you take off the gown, you have to make sure, also the gloves, that you peel it inside out, because all of the viruses or the pathogens will be sitting on the outside. The second method does the glove and gown at the same time, and you basically just make a big burrito out of it, roll it inside out, and pull it together and put it aside into a separate container with a lid. It follows the goggles, face shield, mask, or respirator. Again, you wash your hands. This is a very, very, very important step, and this is a step that we in our office, and so do many, many other of my colleagues, are practicing with all of our team, because we are so used, including myself, to touch the outside, and it's human, I guess, the nature, touch the outside, touch the mask, touch this, that we don't think about this is highly contagious, potentially highly contagious. Proper staff training and practice is extremely important, and it's fun when you do that in a team together. So we have many different mask options today. We have N95, KN95, which both of them are not really available. And we have many homemade models. And I enjoyed this little cartoon because, you know, you see a variety of them out there and you often wonder, how good are they? And anything, the thrifty, the handy with the needle, probably a bank robber, and shouldn't be allowed out of the house. The shouldn't be allowed out of the house does not really have much of a seal on either side of it. So any pathogen can escape that beside, you know, the joke. If you have a simple cloth, it really prevents the droplets transmission. So it protects a lot other people from you being also a possible carrier. So let's move on to the mask options that we have today. Shortage. That is what we have. We have low availability. The supply chain is dried up. There is a lot of counterfeit.
Along those lines, early on in this, we ordered a bunch of KN95 masks. We thought we were prepared and ready to go. And at that time, those masks from that manufacturer were on the FDA approved list. They no longer are. So yeah, there's a lot of frustration out there. But I did really enjoy what Dr. Troelsch had to say about surgical masks. And so.
Yes. So that is one of the things that, as a matter of fact, happened to me as well. And so to many, many others. Yeah. So now it's interesting. One of my dear colleagues who had ordered a very, very large amount of KN95 masks that, as a matter of fact, are from China. N95 is fabricated in the United States. Received them, and also we went to the site and saw it is counterfeit. So it went, as a matter of fact, from 80 to 14 approved and verified vendors on the site. And they were wondering if we can just use the counterfeit masks, since we now spend so much money for them. We can just use it for maybe an exam, or we can still use it. And there is tests that have found that many of these masks, and I want to draw your attention to it, and it is ultimately your decision what you do as a clinician or hygienist, but there is a large variation. A large variation, it can go as low as 24%. And some of them may be up in the 90s, but it is all over the map. As I said, the CDC approved vendors are now down to 14. Make sure that you test it. Any mask that you buy, ask for the number and check it out before you purchase it. I have had 2 orders that came in the wrong way as counterfeit. The recommendation, although the supply chain is kind of dried up, is really to go through your dental supply vendor. Yes, we have to wait for months and may get 1 or 2, and they are, you can get 2 boxes here, 1 box there. Work with many of the vendors in order to get your supplies satisfied. So there was questions, what is the difference between a mask and a respirator? It is the fit. The peripheral fit that is described, and the face mask basically has ear loops. It is for large droplets, close contact. The respirator has a band in the back of the head and a very special way on how to put it on and off. It has filtration capabilities for small airborne particles. It has to be under normal conditions fit tested, and it has to be seal tested every time you take it off and put it back on. Now, during the interim phase, the fit test has been abandoned. Remember that the PPE must live up to the challenge of the procedure, which in this case are set by our regulatory components. Can I reuse the N95 respirator? Short answer is the interim guidelines allow the reuse, but you must pay attention that the structural integrity, the functional integrity, filter is not damaged, contaminated. It can also be used beyond the expiration date, but you must tell the person that it's expired, that wears it. You must never wear it on patients that are infected or potentially infected. And do not use it if the seal check fails, but that is common sense for all of them. Now, when do I have to discard my N95, the one that I have and I'm cherishing after all these counterfeits that I finally received? Very simple. When it's wet, when it is soiled, and when the seal is compromised. And a dear colleague, assistant of mine who had babysitting duties compared that to a baby diaper, because when do you change a baby diaper? When it's wet, soiled, and the seal is compromised. So this way you will never forget when to change your mask. How do we decontaminate an N95 mask? Because we want to reuse it. And they are interim guidelines that approve the decontamination of an N95 mask. One of them is the vaporous hydrogen peroxide, UV, moist heat, and if all of the above are unavailable, there's a YouTube video, as a matter of fact, and I can provide you the information on that. Microwave generated steam, liquid hydrogen peroxide, or alternatives. Now, for how long can you wear these masks? Dry heat oven, based on the recommendations and guidelines, twice. Hydrogen peroxide is good for 3 times. Radiation, depending on how it preserves the integrity of the mask, you must always check the integrity of the mask up to 3 times. And we also have a very simple method that I did not mention, and that is you can have a Tupperware container, put some holes in there, or a paper bag, and remove the mask without touching the outside, which is very, very important, and place it in the container. Seal it, leave it in there for 72 hours, 3 days, and it is okay to use. For that, we made a little demonstration movie so that you see that.
All right. So, I'm gonna use this box. Go here, open it up.
This is a counterfeit KN95 mask, just so that you know. Back then, it was still on the list of the
This
CDC.
KN95.
So very careful with it.
And it closed. So I'm gonna keep this for next time. All right.
Good. Where can I be fitted for N95 respirator? In Washington State, there's one place, Northwest Response, that I heard. The fit test is currently not required. So just to answer the question, this is what it is. Seal test is required. Ultrasonic instrumentation, any concerns? No, no concerns. It can be performed with proper protocol and standard precaution, which is high vacuum PPE, turn down the water spray, and there's no evidence for anything else. How do I clean my goggles, face shield, loop between patients? Simple, water and soap. We must remember in the state of Washington to give reusable eyewear to patients. Any questions at this point? Or should I just
Yes,
keep going?
we've got lots of questions. So let's just talk about ultrasonics. Let's talk about Cavitron. Let's talk.
Aerosol related air question.
Yes. Oh, that's your next session.
Uh-huh.
Well, then let's let you continue there, and then we'll hit those questions. Okay?
These are, yes.
Thank
So
you.
aerosol related air questions is this section. Question, do we need air purifiers? We do not have any requirements. However, we have research that supports old research, we talked about that on Friday, that shows natural ventilation, windows, doors, significantly are beneficial in reducing the rate of new infections. In places where you don't have a window, however, ventilation or air purifiers might be beneficial because it creates air movement and cleaning. Now, we don't have much research on the effect of that at this point, but just from the engineering standpoints and the studies of that, it has been shown on some of the old studies. Now, one of the systems that I personally, as a matter of fact, purchased, and it's because I have allergies, and it is a medical grade air purification system that has different components. It catches the part. It has a it is basically a 6-stage filtration process, HEPA filter. It has a part in it that catches the fungus, the bacteria, and it, as a matter of fact, goes down to a very, very, very small size that catches viruses as well. It has a part of it that ionizes particles, pathogens, so that it becomes heavier and falls down to the floor versus being floating in the air with an aerosol. And it gives a very fresh feeling to the air. It has, as a matter of fact, Dr. Christensen had evaluated that, I believe, and I don't know what grade he gave to it, but that is one of them that I wanted to throw out as information used in medical institutions and for those that have allergies and other health concerns or are concerned, is there. It turns around the air in the room quite fast. It depends on the room size and on the size of the machine. And there's a formula to calculate that. Hygiene and aerosol. Are there any interim treatment guidelines? This is pretty much the elephant in the room, and I should skip this.
No.
Okay, I will go there. So it's an interesting question because the CDC, and this is my understanding, and I might be wrong, the CDC interim guidelines allows only for emergency dental or hygiene care. However, we have our state reopening on the 19th. There is like this, it just is not logical. It does not make much sense. And what does it really change on what we do and on the real threat and the presence of the virus? The virus is here, and it is here to stay. Dentistry is here, and we're here to stay. So the only normal way to really enhance and update our system is to start working together with it, with the facts that we know, and incorporate that, evaluate it, update our systems for the maximum safety, security of our team members and our patients. Use the standard precaution. There is no interim treatment guidelines as far as I'm concerned as a dentist or as a periodontist, because that is truly what we're here for. Hygiene, what is considered emergency services? Another question. So you see on this picture, a big tear on a 6-year-old cheek. And you see a beautiful ring of calculus on the 2 newly erupted 24 and 25 and some gingival inflammation. This boy could not bite down anymore. That, as an example, is something. It is pain, lack of chewing, cannot take in good nutrition, and you need to see them. Is extraoral suction device helpful in aerosol management? What we know from studies is that a high vacuum suction system with at least 300 liters per minute in combination with a saliva ejector is efficient and effective in reducing aerosol formation. if it is used properly, which means you have to really train yourself and we have to train ourselves and our team on how to capture the aerosol, how to position it so that we maximize it. And how much is reduced? Between 90 to 95%. Some offices and some setups can possibly do four-handed dentistry. If it's an option, great. If not, there is two-handed dentistry, which is absolutely been documented to show the same results. We might need to utilize some aids, like utilize an Optergate to hold your lips aside, or Newberg, and to reduce that way effectively the aerosol. Let's take a look at how it really works. In my practice, I'm a periodontist, so we use airflow. We use a lot of guided biofilm therapy. A, because it does reduce the least amount of aerosol. B, because it just really fulfills the treatment objective that I have as a periodontist. So let's take a look at this. This is the animation done. We all know that. Right.
Karbakhsch, we can't hear you right now if you're speaking.
Thank you. The amount of airflow or the amount of aerosol that is generated really depends on the speed and the water that you put in there. And not every aerosol is and contains pathogens. That is something that we must keep in mind. If you just hold up an ultrasonic instrument or an airflow and push the start pedal and the water spray comes out, it is not contaminated. It is like a shower. When it touches two structure and surfaces, and that's where the pre-procedural rinse comes in, then it can contain pathogen. I have a few of these videos here because it shows how the aerosol is generated when it hits teeth, it hits brackets. The reflection of the aerosol might be a different one. Around implants, around patients that are systemically in need of periodontal treatment, non-surgical therapy and care, such as a patient that is in chemotherapy and must have the infection of the gum tissue. And 70-year-old out. One way to observe how much aerosol also is there is you wear a face mask. If you have a lot of water spray on it, you have some.
Karbakhsch, we can't hear you while the videos are on.
So if you wear a face shield, one way to reflect and see how much aerosol actually is produced and how much really hits you or splatter hits you, you can really see that on your face shield. Adjusting your position, adjusting your technique, adding other HVE or different design of it is something that one should be doing if the aerosol is not controlled. And I have done that myself, and it really enhanced my positioning around the patient. Now, the next question that we have, do we have to change PPE after each patient? Nope. The CDC interim guidelines says that you must change if it is visibly soiled or otherwise damaged. So unless it is visibly soiled or damaged, you do not need to change between uses or patients. So basically, you could wear it for an entire shift or all day. Can scrub bottoms be worn to and from the office as long as I wear a lab jacket throughout the day that is long enough? Yes, it can be done. This is an example of all different options for the HVE. And I believe this one is hard to get. I'm not sure. I'm pretty sure that a few of them may have shortages. The Relief is one that apparently is very popular these days. My Hygienist has this, the New Bird, I believe it is called. Any scientific evidence that there is COVID-19 and aerosol related by dental procedure? As discussed earlier, we don't have strong evidence at this time, and we need more research. We do know, however, that SARS-CoV-2 or corona is spread through respiratory droplet and is to be found everywhere when we, when we have a carrier, a symptomatic or asymptomatic patient. It remains viable and it is on surfaces. Surface decontamination is extremely important. Habit forming is extremely important, not to touch surfaces and then touch your face. It's also important to remember that you have to disinfect your operatories in full PPE. I made you a little cheat sheet about the aerosol and again the droplet, which comes out of the medicine. And I used broader terms. Droplet, bigger drops, shorter travel distance. It's defined as 3 feet, 1 meter. And that's where we have our recommendation of 6 feet or 2 meters. They carry usually a bigger virus load. It's like having a bigger tummy. You have more in it. A higher dose might have a higher or more efficient inoculation, which means potential for causing an infection. The aerosol is the airy floaty, it stays in the air, has small particles, travel longer distance, and at this point does not, although it is present in some studies, but it has not been shown to cause inoculation or an infection, transmission that resulted in an infection. Disinfectants. Ethanol and hydrogen peroxide. Please check your EPA site for the disinfectants that you have and follow the manufacturer's instructions. The time that a disinfectant needs to sit on the surface varies between 1 to 10 minutes, some of them even longer. How to clean surfaces. My recommendation and I know there's two different ways. Some say wipe, spray, wipe. I prefer it the other way around based on the following. The surfaces are dirty. You have surface contamination with a virus. Now you grab a cloth and you wipe the virus all over. I prefer to spray first, let it sit for a minute, kill the virus, then wipe it. Then spray again, allow the alcohol to dry. And I like alcohol because it has to be higher than 62% in order to be effective based on what I read. Allow it to dry so that it kills the virus. There are two products, I believe, that have gotten a lot of attention that are based on, again, ethanol and hydrogen peroxide. Do not use a cotton cloth. Oh, there it is. So what if a patient we treated let us know within 14 days that they have tested positive for COVID-19? Well, that's not good. Gonna have to close the office and all staff in contact notify. You have to close the office. All staff in contact with that patient has to be notified and quarantined for 14 days. And at that point, of course, if you have symptoms, you would be going to the hospital as a patient, and if not, then you're out of the woods. Patients with a history of testing, patients with a history of testing positive and recovered, are there any guidelines? Nope, just follow the standard precautions. They're healthy. If they have no symptoms, you can just treat them. What do I do if a staff member tests positive? We have a wonderful ADA toolkit, and they have tons of resources in there. And one of them is exactly this. You or a member of your team has tested positive, step by step, to go through all of that. Aerosol in front office, are there any guidelines, any protections for front office? For the front office, the biggest risk is the droplet transmission of the patients coming close to your receptionist, to your scheduler. So what we did in our office is to hang a plexiglass sneeze guard, basically, and to mark area that outlines, this is the 6 feet, please don't come closer if they come into the office. Now, this is a perfect time to really communicate with every patient if you change your office operation and procedures. Stay outside, stay in your car. We come and meet you at the door. My surgical assistant comes and meets you at the door. We have paperless check-in procedures and guides you exactly into the operatory. What we also want to do is we want to avoid talking too much, because what happens, a droplet is transmitted by talking. As a standard precaution, I have all of our team members, and actually they really appreciate that and like it, wear a mask all day long. And you have to change the mask, they say, about 4 to 6 hours. So at lunchtime, the mask, if it's soiled or it's wet, will be changed. If not, for the front office, after and behind the sneeze guard, I believe it is okay, since they're not really in contact with any patient. Social distancing or physical distancing is very, very important. What is also important is to keep all of the surfaces clean. And that brings in updating the new procedures in order to be ready to coexist with this new virus. Surface cleaning, every half an hour, every hour, deciding what you like to see in your office must be executed. Have a log, communicate that to the patient, bathroom, doorknobs, computer mouse, computer keyboard, computer monitor. If you have those little check-in boards and paper, those need to be wiped down. And basically everything that you can touch or a patient can touch. Check in and checking out a patient, same procedure, the pre-screening. There's pre-screening questions that will be asked when the patient calls to make an appointment screening, and then a pre-procedural screening as well. So, any questions at this point?
Yes, I think what we'll do is we'll try and bang off a bunch of these and we'll merge them together. So let's just regroup on the ultrasonic scalers, cavitrons, hygiene. We're going to still utilize those ultrasonic scalers. We're going to use high volume evacuation. If we have isolates, etc. When we can, we could use handed dentistry there. Let's see, what else along those lines? Are you going to wear a face shield when you're using a cavitron or piezo, or do you feel that's necessary?
No, I can't stand them.
Yeah. Yeah, I think you hit the nail on the head there for a lot of this. We're going to be gung-ho about wearing face masks and N95 masks and all this, and it's going to take about a half a day, and people are going to realize it's pretty miserable, and we may back off on that. Would you work without a fan? Or somebody says, I cannot work without a fan. Would that be contraindicated?
Without a fan?
Yes, I fan blowing across them. So
I think that's, as a matter of fact, that creates air movement. It's just one thing that one should really be mindful of. Which way is the air blowing? I know that there is a study, I cannot remember where it was and when. It must be in China, because most of our studies right now come out of China, that related to SARS-CoV-2. And I believe it was in a restaurant setting. And there was an air conditioner that came out. And what they found in the study is that a person that sat somewhere in the middle of the room, and that everybody behind them, there was a much higher percentage of infection and contamination with the virus versus those that sat closer to the wall, and the fan or that was blowing into this restaurant was moving more or less the virus from an infected host into others. So which way do you want to have it? So you have to really look at which way the wind comes and it blows, so that it cools you down, if you want to do that, and it takes a potential pathogen away. Now, this is nothing that I really can decide this is just an academic discussion that I'm having, so that you don't basically blow it on yourself, the viruses. And with that, you will increase, of course, the potential risk of exposure. That is something that cannot happen. So the legal part of it and the recommendations is something that I cannot really answer. But the direction of the air movement should be away from you to decrease the risk of exposure. An alternative to fan is to put some ice cubes down your neck.
Oh, jeez. Yeah, I would say it's fair to say that you do not want to be taking those droplets and pushing them further out, especially pushing them towards your assistant or anybody else in the room there. Yeah.
I do run hot myself too. I cannot even think about it.
Okay, what are, somebody's asking about, you have an older hygienist with high blood pressure, almost age 65. What are some work recommendations there? Wow. I'm not sure if that's the person that's asking is a hygienist or if it's the person that owns the practice. I would be careful about getting into anything like talking about age, etc. Yeah. I guess, yeah, I know that if we're over 60 years of age, we're more susceptible, etc. But I think you're opening up a can of worms from a legal standpoint there, and I would consult your, and that would be a good question for Tyler Jones on Thursday. So let's not touch a legal issue there. Okay. Henry Schein ran out isolation gowns and no future availability. Other vendors are charging $5 to $11 for gowns. What should we do when nothing is available? And I find this interesting that all of a sudden we've decided that we have to switch to disposable gowns and not use, you know, lab coats and
you can use anything. You can use lab coat, disposable, reusable, absolutely. It just has to have the requirements.
And of course, if it's a procedure that we're expecting some splatter and that, then that's probably the time to pull out that $5 to $11 disposable gown. But would it be fair to say we don't need to use a disposable gown on every operative procedure?
It is not a requirement as far as I understand. You have to have a coat on, an overcoat on, but it does not need to be disposable. And it has to have long sleeves for the staff.
Yeah, absolutely. Knee length,
Knee length and
button up, seal at the cuffs, yeah. Okay, in regard to Dr. Catafucci's method to disinfect the KN95, would it be better to expose it to room air to let it dry out? By sealing it in the Tupperware, moisture in the mask can be maintained, and won't that prolong the survival of COVID-19 on the mask?
Well, you nailed it. We did not, I guess we didn't have a burr to drill holes into the Tupperware. This was a demonstration movie, and there should be holes in there, which takes care of the ventilation. Excellent observation. And no, you must have holes or the paper bag. And yes, you should absolutely, and that dries it out. And that's the whole concept, 72 hours, so it dries out and the virus dies. The virus doesn't like oxygen.
Okay, I like this next question because it says, I'm not sure what to do with pre-screening question. Have you been in areas where COVID-19 is spreading within the last 14 days? COVID-19 is spreading everywhere. Is there some guidance on what to do with the answer to this question?
I agree with it. I had this conversation myself, and I agree with this. It is a weird question when you think about it. Feels static. What I encourage and invite everybody to do is, what do we really want to find out with it? What is the purpose of our question? We basically want to know if they went to the beach party in California, or we want to know did they do something that is outside of their normal activity? Did they meet people that they usually are not socializing with, or were encountering with, or came in close contact, too close, closer than 6 feet? It is, for me, for myself, I want to find out if outside of the home circle and work circle, and I must stress again that the social, or I don't like social, the physical distancing should be respected in the office, with friends, with co-workers and teammates, wherever we can, because that significantly reduces the risk of exposure, droplets, travel. And so when we get outside of our normal room and meet somebody, we want to know, have you done something that you didn't do before? And something unusual. Have you met somewhere? Was the cash register at the Metropolitan Market getting too close to you? I mean, something that is unusual. The reason is for us to gauge the potential risk of that. The reason is not to treat it, that is and falls back into the decision-making criteria of a doctor, is, do I pull out my N95 mask, or is a level 3 mask okay? Because we have to manage our supplies. We have to see what we have, and we have to pick the best PPE for the procedure. Okay, so if I can gauge the risk of a patient that comes in that I don't know before, I kind of have to tweak and tailor a little bit the questions to find out what is the risk for possible previous exposure or something that they didn't do before. And then I, as a doctor, will decide, am I gonna see them in 2 weeks? Am I gonna send them back home in 2 weeks and see them back? Or can I take this risk for this procedure or this appointment? Does that answer the question?
Yeah, that's just fine. I think it's a question that you know, is being used by a lot of dentists. And then keep in mind, just because we're in this area, there's other places that haven't been exposed to the COVID-19 like we have, and it's kind of a standard question. Yeah, absolutely. Okay, somebody asked, I thought the new CDC and ADA recommended no cavitrons for now. I don't know that. I'm going to certainly take a look after, but I have not seen that.
And remember, CDC and ADA provide recommendations. You as a dentist make the decision. And that really is based on the risk and the risk evaluation.
Yep.
OSHA, WISHA, or DQAC are basically the regulatory and as far as I hope I don't use the wrong words because I mix up my German and English sometimes, components here. And CDC and ADA, I did not see it, and I did not see that as a law.
Okay. Yeah, absolutely. Okay, let's see. I've heard about waiting a period of time before cleaning the operatory, allowing anything that might be in the air a chance to settle and land on the surface before immediately cleaning.
I haven't
seen that either. If a virus can enter the eye, should patients and providers be wearing fitted goggles like a swimmer?
If you love them, do it. If it makes you feel safe and good, do it. It definitely will seal it. I hated those when I was swimming, and there's nothing wrong with wearing them if it makes you feel good and safe.
Okay. Can you please let us know if there have been any updates from DQAC or WSDA regarding if in fact we're opening May 19th? To our knowledge, that has not changed, that we're to be out through May 18th and that we may go back on the 19th. There was concerns that the governor today in his press conference would change that. I haven't had my phone blow up, so I'm assuming nothing has changed there. The Dental Quality Assurance Commission was not able to meet last Friday. They're going to be meeting this Friday at 1:00 p.m. And that's all the information we have on that right now.
I was thinking exactly that on my phone too.
Yeah. So there's also, can WSDA or WAGG please help us all get proper PPE? You know, one of the issues there is when we're going out and getting these PPE, these masks, these, and let's call them what they are, the respirators, the N95 and RN95s are considered respirators. And as you can see, it's pretty tough to vet these vendors. Dr. Karbakhsch did mention that we went from 80, suppliers down to 14. So the WSDA and WAGD really can't get into that business. There's too much potential for problems. Okay, is it possible to have some patients that have reactions to hydrogen peroxide?
Like what?
Well, I don't know. I'm not asking the questions. I'm the moderator. Okay.
Well, I guess everything is possible.
Okay, somebody's asking, where can you get disposable full gowns and feet covers? Again, we feel your frustration there. It's tough right now. You just have to keep working through your vendors.
Now, let me add something to the feet cover. They are not required by law or by OSHA, WISHA. And what I recommend is to get a pair of shoes, leave them at work, leave your clothes at work. Don't take them out of the work. Really, this is what we will be doing. The shoes that we wear in here will stay in here. Now, we do have shoe covers, but the transmission of the droplets on the shoe is very little. Two things that you can do. Number one, you can get one of those sanitizer, foot sanitizer foot mats. They have like sanitizer and a foot mat, where you clean your feet. How do you say that in English?
Doormat?
Doormat, yes, doormat. Thank you, not foot mat. They have there's sanitizing material in a doormat. You can have that. It will clean underneath your shoe, not the top of your shoe. And then you can take an alcohol wipe and wipe the top of your foot. And you can make that as a standard procedure in your office if you're concerned about a possible droplet. The risk is very low.
Okay. They're just asking for suggestions regarding air purifiers, and are they necessary in every room? I think we covered that. No, they're not. Okay. In your mind, what's the minimum PPE standard for using ultrasonic? N95 or level 3 with face shield?
The highest level under the interim guideline that you have. So if you don't have N95, level 3 and face shield is fine.
Okay. Somebody made the statement ADHA interim guidelines say hand scaling and only no on ultrasonics, etc. That's fine. That's a guideline from an outside organization. That's not mandated by any law here. How can we open if we're still in lockdown? Yeah, this is kind of funny, isn't it? We talk about the stay-at-home orders and that, but again, we go back to what the guidelines are from the governor right now and his original proclamation, and with the interpretive statement, and WSDA has reinforced that time and time again. Somebody asked, can we get tests for our patients? Yeah, good luck.
You can actually.
Yeah, but yeah.
You can. I just got an email that a couple of days ago that we can get the antigen test. Excuse me, the antibody test. For home use, and it can be purchased. It is made in China. And I have not done research on it, but I got that email that it is for home use there. I can research that more and share that with you, Dr. Hess.
Yeah, that's terrific. I think there's a lot of information out there about that too. I think Dr. John Coyce posted something nice on his website about that as well. Okay, we use a steam cleaner for our floors. Is there something different we need to use for the COVID-19 virus on our floors?
Do you have carpet floors or hardwood floors?
Yeah. Well, I'm assuming it's hardwood if they're using a steam cleaner.
I'm not a cleaning expert.
When is it okay to provide services to patients in nursing facilities? I can see the concern there with the fragile population. The chance of bringing it in.
Excellent question, as a matter of fact. I believe whenever they let you in. Because I think it's still locked down. I don't know if nursing homes are going to be kept isolated for a longer time. There's one, the legal aspect. The other aspect is I would take somebody out of the facility to provide the care to minimize the risk for others.
Yeah. Okay, a question about hypochlorous acids, spray disinfectants, and fogging. Is this safe to do between patient appointments?
Why?
Yeah, I don't know much about the fogging. I know it's been mentioned in the last week or so, but I don't know much about that.
It is definitely a method. It has some drawbacks and disadvantages. Normal disinfection, spray, wipe, spray, a minute, 2 minutes, you're done. You have to manage the time between the patients because we already are going to be running slower and have to be much more careful by putting on, putting off, donning, doffing our PPEs. We cannot take any shortcuts because we cannot break the chain of infection. So our focus here must be really on not breaking the chain of infection and honing our skills and becoming better and in the execution of the skills that we are trained to do, and adding others that we have to update in order to be in compliance with the safety standards that we want to provide to our patients. So the way I approach it, I choose what I want to add and what not. What does do the job in a simple, clean, straightforward way without me killing myself with all of this PPO stuff, and allows me to run the business on the other side too. We have allocated about 20 extra minutes to it to start with, to an appointment time. We significantly have slowed down, of course, the traffic and incoming patients and scheduling, and we will update that and evaluate that as we as a team grow together and really develop new systems, the systems that are there and will be there to coexist and live with COVID. That time has to be given. I do not see myself running around with a fogger a year from today. But if we look at what we want to achieve, what do we want to achieve? We want to, sterilize or disinfect the room. Not sterilize, I apologize. Disinfect the room. What gets you from A to B quickest, based on science, least amount of work, least amount of money? That is my recommendation: to train, discuss with the team, and to come up with systems to implement it.
Good. I think you hit the nail on the head there. I think when we go back, what we really need to do, we need to spend time with our teams first and get everybody up to speed, get our teams comfortable. Otherwise, we are not going to be able to deliver care to our patients if our teams aren't comfortable. What are your current thoughts on air polishers?
I love them.
I do too, and I believe Dr. Steve Machida asked what that water pick spray thing was. And was that your air polisher unit then?
Yes, that is yes, EMS piezo, the master unit.
And what solution are you running in there? Are you running a glycine or a powder, or what is it?
We have all of them.
Okay.
I'm happy. It might take a little bit into perio. I'm happy to share that information with you, what we have.
Okay.
The particle size, we have a large range depending on what we use it for.
Okay. So yeah, it would be similar to the ProfiJet powders and all that are out there.
No, it's much finer. We have the it is between 14 to 20 micron, the powder size.
Okay, terrific. Did you say the fit test is no longer recommended for the N95s?
It is abandoned. The interim guidelines of the CDC does not require the fit test.
Okay.
But the seal test, the one where you can feel the air escaping when you do the seal test, is required every time you take the mask off and put it back on. So don't touch your mask. Once it's on, it's on.
Okay. Describe that seal test, if you would.
Well, it's much easier to see it on a little YouTube. You basically have to put the mask on in a very special way, you know, not to get the little, it goes around the head. There's a bottom and a top part. You make sure that it fits under the chin. You put over the nose, the bridge of the nose. Your hands, of course, are clean and gloved. And you put it over the mask, and you take a breath in and sharp, quick breath out. And you see when the air escapes, the seal is not there. So you basically, when the air comes out in these areas and other areas, you don't have a tight enough seal. I personally, my experience, I have wonderful, very few, unfortunately, only left level 3 masks, which has a wire on the top and one on the bottom, that are much more comfortable and a better fit than my N95 that I have here. So the seal of, I haven't met my N95 that I have don't fit me that well. So I really have to maneuver it around to get a good grip and a good seal.
This question is, are your staff using the respirators in the picture you posted or N95 masks? I think what we have to emphasize here is the N95 is considered a respirator. Correct?
My staff was not on any of these pictures, I think.
Okay, well, don't worry about that aspect, but the fact that the N95 and the KN95s are considered respirators versus surgical masks. Okay, would you recommend opening the windows before and after patient treatment? Yes.
Have them open if you can have them open, and you have windows, have them open all the time. But make sure that the flies don't fly in, and have like a little screen. Maybe the summertime comes around, and depending on where you are, you don't want to invite uninvited guests into your room, into your operatory. Ventilation is great. I do this in one of our clinics. We have windows, in one of them we don't. And natural ventilation, thumbs up.
Okay. If I don and doff PPE properly, use all required PPE, follow all safety and infection control protocols, do you think we should still separate and sleep apart from our family members during this stage of the pandemic?
Why would you do it to begin with? Are you worried about being positive? I mean, okay, question, I will answer. If there is truly a suspicion and a concern that one has been in contact with a host or a patient that is positive, and you put yourself in self-quarantine, then you definitely should not be in contact with your family. If there is no such thing, if there is no risk of infection, contamination, exposure, then you should not, unless there's another reason, you should not be, there's no reason to stay away from your family when you go to work. It's absolutely normal. And we live amongst many, many bacteria, many, many, many pathogens, and we have done so for years. We have viruses, we have bacteria. Dentistry, as a dear friend of mine said, is not a clean profession. We work in in a dangerous setup. That's why we have all of these training, infection control guidelines, and all of these guidelines and rules. And that is also the reason why in one study, as a matter of fact, in China, when SARS and Corona, COVID-19 broke loose, a population that worked with those patients, that was dentists, they really didn't get infected, but the medical doctors, they contracted and got infected. Very interesting. Why? Because we're so used to the standard precautions. So if we do that and we continue to do that, nothing changes. But we must be very, very, very aware and conscious of not breaking the chain. And we must watch and help each other to achieve that, because we all get sloppy. We all break it here and there. And it is not personal to remind somebody to be mindful. It has to go to the point where it becomes habit forming, that we do the same thing out in the society as well, where we are mindful of the distance on how we can contaminate, or how our droplets can travel, how we can have a respiratory transmission, so that we don't get too close to old people or people that might have underlying systemic disease. We must take that out, and not like what we see the moment California, the lockdown is down, everybody's on top of each other on the beach.
Okay, somebody was asking, what was the disclosing purpose in your video?
Oh, the biofilm. That is the biofilm. That is a perio lecture. I'm not going to get started, Dr. Hess.
Nope, please don't.
I caught myself. The
Yes.
Persian came through.
Yes. Okay, this is interesting, and I haven't had anybody answer this yet. What is going to happen with our microscope users out there that...
Oh, beautiful question. I wish I had a picture. It's very simple. What you can do is you can take a bag and put it over the microscope, and where the little eyes come out,
Yeah,
you make little holes in
yeah.
there. You tie it on the bottom. You wrap it basically up, and you can, just the top part is open. You can utilize it that way. It's very, very simple and very straightforward to do that.
Terrific. I'll answer this. Is there a website to determine if N95 are real or counterfeit? Yes.
Yes.
The FDA website. That's easy enough to find.
Let me see where I have the picture here. Let me see.
Okay, we'll continue with the questions as you're finding that. Are you scheduling less patients per day to allow more time between? Yes, that's the answer there. Somebody asked, is it okay to remain closed if we are not ready to open? Absolutely. In this time, don't do anything that makes you uncomfortable until you're ready to go back, until your staff members are. You know, we don't need to jump right back in and be running at 110%. Realize we've got to ramp up. We've got patients that are uneasy. We've got our staff members uneasy. Encourage you again, you got to get on board with your staff and let them know all the things that you've been doing to keep them healthy and provide a safe environment for both them and our patients. Somebody didn't like our comment on that we hate the face shield. Sorry about that, but we've got to be honest. We've got to figure out what's going to work for each one of us as clinicians, and what we're actually going to do. And I think we're going to see that people are going to quickly realize the N95 masks, they're not going to enjoy them. So you got to look for other solutions out there. And I think from what we've heard throughout the lectures today, that a level 3 surgical mask is a very good option.
Now, one thing, Dr. S, that I want to add to it, a face shield, just to correct them, that was a personal statement that is based on a legal requirement. If you have goggles or loupes with side shields, a face shield is not required. It is not a requirement. So it is a choice, as long as the other parameters are satisfied.
Okay, let's see. Are you taking your staff's temperature every day?
Yes, twice. this is the last part of it, which is basically just putting through what we're doing in our clinic and flow charts. We don't need to go through that, but I can talk through that. We do it in the morning, a self-check. We do the screening questions on each other. And we sign, we basically do the same thing. We do a quick little initial and it's on the ADA toolkit and that has to be private, an initial for the health check for our staff members. We encourage them to tell us if they feel sick or not up to par. It is the self-responsibility.
Terrific. And you hit on it has to be private. Tyler Jones, the attorney there, stated that in our state here, you can not have just one sign-in sheet for the whole staff. It has to, because of HIPAA regulations,
Yes.
be private for each staff member. Okay, could whitening Listerine be as effective as Listerine and Peroxide?
No. Well, let me, Listerine, there's two things that work for the disinfection and has shown in the studies, which is the ethanol-based and hydrogen peroxide. And those are the ones that we know by the studies and the recommendations. Now, if APA approves it, I would recommend that you go, and I'm not, as I said, a specialist in the cleaning world. If the EPA approves it for certain use, you must look at the kill time of it. It might be very long, and for the use of it. And if it's on there, you're good.
We're still speaking of mouth rinses, right?
Oh, I heard
Yeah,
Lysol. I heard
no. Listerine. Listerine makes a whitening mouth rinse. So, yes. Just to reiterate, we're not suggesting anybody leave Lysol in the mouth. Okay, sorry about that. You've been at this a long time. I know it's tough to sit there and.
I couldn't hear you. This microphone is not very strong.
Okay. Let's see. How do we treat medically compromised geriatric patients? Any recommendations? I think we covered that. But
we treat every geriatric patient under consideration of the standard precautions, which means you check their health, you consult with the doctors, you consult what their immune system is, you evaluate the risk of the treatment, and you choose the treatment modality. You are the doctor. That is the safest given the circumstances and the patient.
Do loops have to have side shields? Yes. Somebody's asking, what about the higher price to run the office? I mean, that's something we can't answer here. That's just, it's cost of doing business right now, and things will have to adjust. Do we have any idea how many dental professionals contracted the virus while working before knowing about implementing extra precautions?
To my knowledge, the fact, and I actually was talking about this to a colleague of mine, what we cannot say whether you contract the virus at work or outside of work. We don't have tracing apps right now that are available here, and we don't have the same systems in Germany. They are very organized in it. Somebody got sick, they went back into the Stone Ages to see with whom they were in contact. And with that, they could really monitor the exposure of people. That hasn't happened here. There's not enough tests, there's no tracking, and it's hard to say where. So we don't have the answer for the question.
Okay. This may be silly, but when you have patients pre-rinse, are they spitting it back into a cup or using the suction? And how many ounces are you using? So very practical questions.
So let me give you a practical answer. Use it yourself. This rinse foams a little bit when you start gargling. That means that you, most probably a minute, if you want to gargle and rinse with it, you will take 2 or 3 sips, because you're not gonna gargle with the foamy stuff, you know, in your mouth. So I have a cup where they can spit in and take the second sip out of this. So it's a two-handed maneuver.
Okay, thank you. Should we require our patients to wear a mask in our office during the time when they are not being seen by the dentist and hygienist?
Yes, that is a
Yes.
my protocol is yes. And you make your own protocols. But I absolutely would recommend that.
And should we provide patients with masks upon arrival after temperature has been taken? Yes.
I can, this is the part that we just skipped. That was the last part. So we're going to do it verbally. Then again, it's up to you, because we have a shortage of masks. I ask the patients to bring their own mask, because frankly, we are protected. We have masks on, we have sneeze guards on. Even if they have a cloth mask, it is their droplet guard, okay? We will not transmit anything to them, and they will not have a droplet transmission out. So I ask them to bring their own. If they don't have, we will provide them a level 1 mask.
Thank you. Somebody asked about finding the handouts on Facebook. I'm not sure if we'll have any handouts available. We'll talk about that. And if we do put some together, we will put those on Facebook. That seems to work the best. Okay, somebody's, if CDC offers only recommendations, are clinics not opening themselves up to liability if they do not follow the CDC's guidelines? I think this is, again, a question for attorneys. If you have any questions about what you're doing, contact your attorney. But in Washington State, keep in mind DQAC and, pardon me, the Dental Quality Assurance Commission and WSHA are the ones that set the rules in this state, and the governor also. So that's where we have to get our guidance from there. I think you said you don't like to wear a face shield. Are you going to wear a level 3 face mask and your glasses with loops?
No, I have an N95. I wear an N95 and my loops, and that is adequate.
Okay, question, what was the disclosing solution again? Somebody wanted that again.
So there's a lot of different disclosing solutions that are available to show the dental plaque, to stay in the plaque. And I don't know what the name is really. Just like earlier, I forgot what the name of the powder is. And now I remember that it's erythritol powder, the very fine powder that we use in air polishing. This is what a 2-month break does to an old lady's brain. And I just wanted to add that for whoever had asked. I can get you a list of the products if you're interested for what we use.
Okay, and somebody threw out Young's two-tone. Okay. And
I think that is correct.
Yeah. Okay, let's see. Somebody asking malpractice questions. You take those questions up with your malpractice provider. We're not attorneys. We can't advise you on malpractice insurance there. I think you covered this already, that you are going to make up the Listerine and Peroxide ahead of time once you get back in the office and get things rolling. Is part of that's, yeah. And somebody asking, they couldn't find the WAGD Facebook site that has Dr. Trollsch's info. How do I get to that? I'm sorry, I haven't been on Facebook here today. I know Valerie was putting that information up there. You're gonna have to navigate around a little bit. I know we're going to work at trying to get the handouts for Dr. Trollsch sent to anybody that was on that email. We're trying to figure that out. So don't be surprised if you get an email from the University of Washington School of Dentistry CE department, and it should or it could be theirs, but we're working on that. We're going to actively try to get that out to you. All righty. I want to just thank you very much to my good friend, Dr. Minou Karbakhsch, and I butcher her name every time, and they send it to me phonetically before every webinar. I guess I'm just stuck in that engram or whatever that is. Just like to say thank you. Is there anything that we stirred up there that you want to say that you hadn't thought of as we were going through here, Dr. Karbakhsch?
No, I am here available if there's any questions. Clothing salt we already had. We just need to strictly understand and follow infection control guidance, something that I've been doing for years. Update our practice protocols to coexist in peace with COVID-19 forever, because dentistry is not going anywhere, and so is not COVID-19, the virus. We need to enhance our knowledge, skills, meticulously execute it, cooperate, talk to each other, team, patient, and doctor, and revisit our practice protocols as required given the situation. So with that said, I want to thank you all very, very much. And the enemy of our battle is about 125 nanometer in size, but has proven to be quite formidable opponent. So we have answered and talked about a lot of different things, and I hope that I could provide you with some of the answers. And if there's more questions, please don't hesitate to reach out to me. I am passionate about what I do. I love what I do, and I know all of you do too. Please don't be scared in getting back into it. You have the skills, knowledge, and the support group that it requires to be successful, okay? And one of the greatest, assets that we have as we continue to practice and learn about the virus, and we learn to coexist with it, with patience and wisdom, as our little friends over the years will show us, we will overcome this as we have overcome many other viruses as well. With that, I want to thank you very much, Dr. Hess, Val, Dr. Hayamoto, and yes, we trust in a better future together, and we will learn together. Thank you for everything, and thank you for having me. I had a great time and a great Zoom lesson.
Well, thank you very much, and thank you for everybody that attended the WAGD Stay Home, Stay Healthy CE series, this webinar, and the others today. We appreciate you spending your time with us. We welcome you to become AGD members and check out the great continuing education we have. We would like to thank our big supporters, the University of Washington School of Dentistry CE Department. Thank you for handling the CE credits. We'd like to thank Comet USA, Patterson Dental for doing the equipment recap today on how to get our offices back up and running. We'd like to thank the International Brotherhood of Electrical Workers 77 that cut us a break on our lease over these couple of months. That really helped us out to be able to deliver content to everybody. Thank you again to the Canadian Academy of Restorative Dentistry and Prosthodontics and the president, Dr. Peter Thompson. Thank you for your kind donation and your support of the Washington Academy of General Dentistry. We look forward to doing future CE events with our friends up in Canada. Just a reminder, tomorrow we've canceled the Braze presentation. Unfortunately, there's no new news for them to report on regarding the PPP loan process, etc. But Dr. Yassin will be back tomorrow with part 5 of his implant study club. Remember, this webinar is open and it's part of our Stay Home, Stay Healthy free CE series. You may have heard me mention Tyler Jones a number of times. He's going to be talking about employment law and dental practice on Thursday. We know things are possibly changing here in the state with DQAC and the meeting on Friday. If we have any updated information or any updated webinars, we'll try and get those out to you as quick as possible. Check at Facebook. You have a greater chance of seeing our information in a timely manner. Sometimes it takes us a day or so to get our information up on the WashingtonAGD.org website. If you missed a webinar, if you want to share a webinar with your staff members, go to YouTube, go to Washington Academy of General Dentistry, and on there you will be able to see any number of our past 50-some webinars. Many of you have asked the question, when is Dr. Trolsch's webinar going to be up? It'll probably be up here before the end of the evening, so we expect that to be up by tomorrow morning at least. And thank you again to our Executive Director, Valerie Bartoli. Thank you to our panelist, Dr. Gary Hayamoto. Thanks for sitting through all these webinars and providing your support in the chat feature. And we'd like to thank one of our CE chairs, Dr. Herb Edwards. Like to thank Dr. Pressett for his efforts putting our website together and keeping that up to date. That's it, other than to say thank you and remind you to stay home, stay healthy, and at least for one more week, and looking forward to getting back and doing dentistry. Dr. Karbakhsch, thank you.
Thank you very much. And sorry about my very sore throat today, dry throat today.
No problem.
I hope it was still understandable.
All right. And there was some really nice comments in the Q&A there thanking you for today. So we appreciate you. And with that, we're going to leave the webinar here. We're going to shut it down and enjoy your evening. Thank you, everyone.
Thank you. Good night.
Thank you, Minou.
Thank you very much, Dr. Hayamoto. Thank you, Val. I don't know if you're still there.